Hey guys, before we jump into selected infectious diseases, I wanted to talk to you about the Ryan-White Act. The Ryan-White Act is a federal law. It was originally passed back in 1990, and it outlines the rights and responsibilities of agencies and healthcare workers when an infectious disease exposure occurs. So you can see how this is obviously relevant to what we're going to be talking about. In 2009, Congress passed the Ryan-White HIV and AIDS Treatment Extension Act, which continued the rights and responsibilities that were part of the original act. Now, under these provisions of this law, the exposed employee has a right to ask the source patient's infected status. But neither the agency nor the employee can force the source individual to be tested. Employers must also tell their employees what to do if an exposure occurs. So the idea behind the Ryan-White Act, or the Ryan-White Act HIV Treatments Extension Act, was primarily to allow for a process for workers, healthcare workers, to know if a patient has some type of history, and if there's been an exposure that's occurred because of an infectious disease, that we can begin to explore what that would look like. It doesn't allow the individual who is infected to be forced into testing, but it does allow for a better process for workers and agencies to have some guidelines on what to do when there is an exposure. Now, federal law further mandates that each agency designates what they call an IDCO, or an infectious disease control officer, whom exposures are reported directly to, and that officer coordinates the implementation, and the exposure control plan and follows local reporting requirements. The idea behind this is that there's one person who controls the majority of those components. Now, post-exposure, employees are required to provide a medical evaluation and treatment for any paramedic or any other EMS provider that was exposed to an infectious disease. The nature of the exposure is assessed based on the route, dose, and nature of the infectious agent. As part of the medical evaluations, employees are entitled to receiving counseling about alternative treatments, the risks of the treatment, signs and symptoms, on the possibility of developing disease, and then how to prevent further spread of that potential infection. There's a ton of available medications, their potential side effects, and then their contraindications as well. Treatment must be in line with current U.S. Public Health Service recommendations. So after a paramedic is exposed to an infectious disease, he has an option to submit a blood sample for baseline testing, and if the employee does not consent to having his blood screened for a specific disease, blood samples are normally maintained for 90 days in the event that they change his mind. So they'll take the patient's blood as long as they consent, and even if the provider says, I don't want to get my blood drawn, I don't want to do that, they've got a 90-day window to change their mind. Beyond that, the infectious disease control officer or other healthcare professional who specializes in occupational infectious disease should counsel the exposed employee and obtain information, The IDCO, or other healthcare professional who specializes in occupational infectious disease, should counsel the exposed employee and obtain informed consent for post-exposure prophylaxis, or what we call PEP, based on current CDC guidelines. All records related to employee counseling, to the post-exposure prophylaxis, all of that is going to be forwarded on to the IDCO. And then from there, vaccines may be made available to the employee if they're deemed appropriate by someone that's involved in occupational medicine. Last but not least, confidentiality is important, because now we're not just talking about your patient's rights. We're talking about your rights as someone who's been exposed to an infectious disease. Those records are all kept confidential, just like any other medical records would be. And then even if you wanted to go ahead and try to get those, you would have to acknowledge a release with written permission from the employee for them to be able to do anything with that information. So as we take a look at that, I wanted to kind of just lay that foundation, because the Ryan-White Act is really important. It was a breakthrough that really gave us as providers rights when it came to infectious disease and exposures. And now we have that testing process in place and some guidelines from our employers to make sure that we're kept safe. So now let's go ahead and jump into specific infectious diseases. The following section of the lesson is going to profile infectious diseases that either may be encountered in the pre-hospital setting or are commonly known by emergency healthcare practitioners. The first major category includes diseases of immediate concerns to EMS. General profiles of other diseases will follow, and you should be familiar with some of the terminology of these profiles and realize which diseases you will more commonly come in contact with through your patient encounters. Regardless, always employ standard precautions. It's your safest bet. When in doubt, mask up. All right, so if we take a look at diseases for the immediate concern to the patient, one of the first ones that we see include things like HIV, hepatitis, TB, pneumonia, chickenpox, pandemic outbreaks such as the avian flu, also dealing with things like Ebola or COVID. The other parts we look at is bacterial meningitis and other components. There's a lot of infectious diseases that are out there that have gained some notoriety or pose a high risk for communicability and debilitating disease. We're dealing with this currently now with COVID-19. Because this is all transmission is very closely related to patient care, we have to really focus on trying to reduce that transmission from patient to healthcare worker, and then understand that how that transmission occurred, and then what we can do to be responsible healthcare workers to protect ourselves and protect our patients. The inclusion of chickenpox oftentimes surprises some EMS personnel because you don't think it's really that big of a deal, but this disease is highly communicable and poses a serious occupational risk for folks who are unvaccinated or previously unexposed to varicella. And so we add that into the mix as part of this as well. One of the big things that we think about when it comes to selected infectious diseases is HIV. The human immunodeficiency virus was the most discussed and feared infectious agent of the modern era up until COVID-19, especially of the past 3 decades. The clinical conditions that cause acquired immunodeficiency syndrome is not a disease per se, but a collection of signs and symptoms that share a common anatomic, physiologic, and biochemical derangements in the immune system. So we're classifying HIV not just based on a specific type, but more so on the lines of a specific signs and symptoms category. Like other viruses, HIV uses the host cell to reproduce, apparent to, in essence, to copy itself, so it can duplicate itself. It makes it very hard to kill because it's actually kept inside of normal healthy cells until they're released. There's no way for us to be able to target the virus specifically until we're actually able to kill the cell that it's reproducing and growing inside. And that's the very dangerous thing when we start talking about killing mass amounts of human cells. It can be very challenging. One of the other big things that we have to look at is pathogenesis. In the past 20 years, we've learned about the dynamics of HIV infections and the development of AIDS. It was first assumed that the virus caused a cellular immune system response, then remained dormant for a period of time. The humoral response was known to produce antibodies within anywhere between 1 to 3 months after an infection set in. Now these things were involving with clinical disease developing in 1 to 10 years. For unexplained reasons, the virus would become active for some, and worsening clinical signs were attributed to an increasing viral population. The extent of the immune cell activity during the incubation phase reported to be from months to 10 years, and was not immediately understood. So there was a misconception, some confusion based on how long it took for this set of symptoms to begin to expose themselves. And we also didn't really understand exactly why. For some it only took a couple months, and for some it took a couple of years. So research continued into the mid-1980s and early 1990s, and it determined that HIV specifically targets what we call T lymphocytes with the CD4 marker. This is just a surface molecule that attaches itself to the virus, to the cell, and a better understanding of cellular immune response and the CD4 markers began to emerge. A reasonably reliable correlation between the disease progress and the disease and the CD4 T lymphocyte counts was developed. So in essence, they were able to actually create a test that would allow for us to tell where a patient was at in regards to HIV or AIDS. Physicians from that point could then predict the development of specific clinical events, such as the CD4 count decreased. For example, the issues with opportunistic infections of like pneumonia with someone who has HIV frequently developed when they seen a drop in their CD4 levels. Now, if the CD4 count, in essence, became a guide to treatment, we could tell based on those levels if they were rising or if they were falling, allowed for us to be able to recognize at what point the immune system is actually beginning to destruct. Recent advancements in molecular biology and more reliable, cost-effective components of obtaining proteins and other biochemical molecules have revealed a tremendous increase in virus production immediately after the infection and have shown that the immune system increases its activity to counter it. Eventually, the number of immune system cells, these T lymphocytes, offset the viral load, reflected by the HIV RNA. This equilibrium or set point may take years to establish, and even during the dynamic phase that we're in, when the equilibrium has not yet been set, measures of viral load is still just the best available indicator of a response to therapy and long-term clinical outcomes. AIDS, once a disease that was almost always fatal, can now be treated, allowing infected patients to live a relatively normal life and have a relatively normal lifespan. Numerous medications, including antiviral agents, have changed the face of AIDS. Although the number of new HIV infections has remained relatively consistent, the number of patients who are living with HIV infections and AIDS has increased significantly, and AIDS diagnosis and deaths have decreased significantly. That's what's allowing for us to know that the treatment's actually working, that treatment is actually controlling the HIV infection, thus avoiding AIDS in many cases. Most people with AIDS do not transmit the disease to others now. There is still a risk to the general public. We know that typically men who have sex with men are at higher risk. African American males are also at higher risk, and then urban dwellers are seen to be as a higher risk as well. There is some risk to healthcare workers. The risk is for effective transmission of HIV to healthcare workers initially depends on whether the exposure to HIV was percutaneous, mucosal, or cutaneous, or just exposed to intact skin. With each of these categories, the risk depends on the fluid type. Blood is obviously the most dangerous, followed by fluids that may or may not contain blood: semen, vaginal secretions, cerebrospinal fluid, synovial fluid, pericardial fluid, amniotic fluid. The fluids just keep going. Urine and saliva are unlikely to contain blood, and so they propose a pretty low risk. So a patient who spits on you or something along those lines, or were to fling urine at you, it's less likely you're going to pick up HIV because there's no blood involved in it. But in a number of the other fluids we mentioned, there are. The highest risk exposure involves large volumes of blood or high antibody titer against a retrovirus in the source of the patient, deep percutaneous injury, or actual intramuscular injection. So to break that down, in essence, unless you're poking yourself with a needle or being exposed to large amounts of blood or other bodily fluids where you have open sores or non-intact skin, your risk of exposure to HIV will go up. Most of these high-risk exposures are involving, again, large volumes, deep percutaneous injury, and actual intramuscular injection, or a high antibody retrovirus titer in the source. Now, the clinical presentations you're going to see primarily are going to focus around fever, fatigue, some sore throat, and enlarged lymph nodes. You may also see some issues with Kaposi's sarcoma, and then secondary opportunistic infections as well, along with weight loss. We know that because their immune system is being taxed because of the HIV infection, that it's more likely that other regular infections could set in, things like pneumonia or any type of opportunistic pathogen. Dementia, psychosis, and other peripheral neurological disorders develops as AIDS progresses, and that's what makes it so darn debilitating. Now, post-exposure prophylaxis, we've talked about this as well a little bit. The primary thing that we're dealing with post-exposure prophylaxis is that because there is no cure or vaccine for AIDS, after an exposure to confirm HIV positive source patient, that's the first thing, the healthcare worker should immediately seek evaluation and possible initiation of treatment by an occupational medicine or infectious disease physician. The CDC has the primary components for this, but they're going to look at what we're trying to actually complete. For HIV positive patients generally do not present EMS in life-threatening situations. However, they do pose substantial psychosocial challenges. In summary, HIV rarely presents life-threatening challenges, but often presents with psychosocial challenges. Take appropriate infection control precautions early, and then precautions should not be a barrier to professional care. Keep that in mind. Standard precautions, we want to make sure that we, again, use appropriate barrier precautions. That includes things like intact skin, protection of our eyes or mucous membranes, things of that nature. Take precautions to prevent injuries caused by needles, scalpels, or other sharp instruments. Remember, sharps go in the sharps box, and be very cautious of how you interact or who you interact around when you're dealing with sharps, especially in the light of a HIV or AIDS patient. Use mouthpieces with one-way valves, bag valve masks, and other devices when ventilating. Obviously, we want to avoid mouth-to-mouth ventilations. Do not put gloved hands to your mouth or wipe your face to your forearm or to the back of your glove as you wipe sweat. Be very conscious of what you do with your hands, as we typically normally do. We also want to make sure that you refrain from direct patient contact if you have any type of open lesions or open skin, weeping skin, things of that. Don't actually come in contact with those because those can still contain the infection. Pregnant healthcare workers should strictly adhere to specific precautions. And then disinfectants and diagnostics, anything that's come in contact with your patient should get readily cleaned after exposure. With hepatitis, general signs and symptoms are going to be typical, are the same regardless of what you're dealing with. Most of your hepatitis symptoms are going to be pretty generic based on any type of infection. Headache, fever, weakness, joint pain. Jaundice may develop clay-colored stools, and dark urine may also happen as part of hepatitis. And then as we look into specifics for each type of hepatitis, there's a couple things we need to pay close attention to. First is we're going to start alphabetically here, and we're going to start with Hep A. Hep A, or viral hepatitis, is transmitted by the fecal-oral route. Typically, it's mild. Many patients are asymptomatic, even though they may have it, and it's rarely serious. It only lasts anywhere between 2 to 4 weeks. Typically, patients recover very quickly. Hep B, this is a serum hepatitis. We also use this when we get our Hep B vaccination. This virus is transmitted through direct contact with infected blood, semen, vaginal fluids, or saliva. This one, again, is including saliva. Hepatitis in general is much more likely to be contracted by a healthcare provider than something like AIDS or HIV. We know that anywhere between 5 to 35% result from needle sticks, and that's the biggest concern. So again, be sharp with your sharp safety. Vaccinations obviously are available and recommended for all EMS workers, and then somewhere between 60 to 80% of infected individuals are considered asymptomatic. It's a very large population. Hep C. Hep C is primarily transmitted by IV drug use or sexual contact. It's chronic. That's kind of where I think of Hep C is chronic. It's a chronic infection that can cause active disease later in life. So it may sit dormant for a period of time and then reactivate itself or reactivate when it's ready. It also can lead to cirrhosis and end-stage liver failure as well. Hepatitis D exists only in the concurrent with hepatitis B. Hep E is going to be similar to HIV, but primarily associated with contaminated drinking water. Hep G is the newest identified virus that we have. Patients who receive blood transfusions who developed post-transfusion hepatitis. We also know that people with hepatitis A, B, or C can also be or super infected with hepatitis G. Tuberculosis is the most common preventable adult disease that we see in the world. Bacteria known collectively as the Mycobacterium tuberculosis complex is what we're looking at here. It's the most common type of preventable infectious disease, and it's most commonly transmitted through airborne droplets. This is a very, very, very common where someone's going to cough. They may be showing signs of some blood-tint sputum, a low-grade fever, things of that nature. Maybe they've traveled throughout the globe recently, international travel, things of that nature. There's also drug-resistant TB, and so there's sometimes where we have patients who have TB that we try to actually take care of them for, but since the 1940s, there's been drug resistance occurrence that's continued. Because of this drug-resistant TB, we try to go ahead and most current CDC recommendations for the initiation of therapy in the United States involve several options for treatment, not just one. One oftentimes is ineffective as it's resistant. Pathogenesis for this, we're going to be talking about the development of the disease normally, which occurs in 6 to 12 months after being infected. And then we see some type of alveolar macrophages that actually begin to attack the bacteria and attempt to wall them off, which is what forms those granulomas. And those components are going to be leads to a lot of difficulty within the lungs. Clinical presentation, you're going to see things like fever, chills, fatigue, chronic cough, and weight loss. They may have some night sweats or hemoptysis if they're coughing up blood. Have a high index of suspicion with anyone that poses an infectious disease, that it may be tuberculosis or some other type of droplet spread infection. For that, immediately you would don an N95 or a HEPA mask. And then make sure you follow your post-exposure plan, right? And make sure that you let your management know. Pneumonia. Pneumonia is the biggest thing with pneumonia is really just trying to identify it from different clinical presentations. In essence, pneumonia could resemble a patient who has COPD. It could resemble someone who has heart failure, and oftentimes these are deciding factors that are going to play a role in your diagnosis. And so we've got to be on the lookout that patients with those underlying diseases are more prone to suffer from pneumonia, right? So your chronic COPDers and your chronic heart failure patients. Those are the most at-risk patients. Your history and assessment, we know that most likely it's going to be a community-acquired pneumonia, and so we're going to pay close attention to the signs and symptoms that are associated with an infection, things like acute onset of chills, fever, shortness of breath, maybe some pleuritic chest pain, and then adventitious breath sounds. In the geriatric patient, the primary sign may only be an altered mental status with pneumonia. They may not have the rest of those common things that we think of for a healthy adult. And also times a lot of the medications they're on will make it difficult for you to be able to tell that. So for pneumonia, primary patient management and PPE, we want to make sure that we support their oxygenation based off pulse oximetry, that we consider the possibility of TB, and then placing a mask on yourself or on the patient. You can go ahead and place just a surgical mask on the patient, but you definitely need to be wearing an N95. Immunizations and then post-exposure management. Obviously, routine vaccination is not necessary for pneumonia, but it is not a bad idea for those that are geriatrics to go ahead and get the pneumonia vaccine. The idea behind that is because they're at a higher risk, if we can limit the likelihood of them contracting certain forms of pneumonia, the safer that they'll be in the long run. And then obviously they're going to do some type of antimicrobial agent, multi-drug resistant strain effect to try to treat that. SARS is one of the other components we think about. It is a version of the coronavirus. Oftentimes people don't think of SARS, the severe acute respiratory syndrome, that we think about. It was again an illness that came from out of China, southern China, in 2002, and then became a global threat within 1 year by 2003. About over 8,000 people worldwide were affected, and just under 800 patients actually died from it. The scale was not nearly as severe as we're seeing with COVID-19, but again, it's still a type of coronavirus. Pathophysiology is, again, was an upper respiratory infection. It was similar to the common cold. SARS-CoV apparently may survive in environments for several days. It's gone on to recognize that obviously close contact and proper hand washing are going to help minimize that spread. And then the incubation period was anywhere between 2 to 7 days, but in some cases lasted up to almost 2 weeks. We knew that the patients were most contagious as long as they were symptomatic. Again, that's a little bit of some of the differences between where we are now with COVID and SARS. Assessment, the first and foremost is make sure that you're utilizing all your personal protective equipment. We want to assess to see, is there any specific signs that can allow for us to identify that this is actually a seriously compromised patient with respiratory distress. We're also going to look for things like altered mental status, 1 to 2 word speeches or sentences because of their ability to breathe. It makes it hard for them to get the air in and out. And then cough, dyspnea, cyanosis, and then severe hypoxia. Most of the symptoms you'll see with SARS is going to be common symptoms: sore throat, runny nose, chills. You may see some what are referred to as rigors, which is sudden proximal chills, muscle aches, headaches, diarrhea, cough, sputum production, respiratory distress, and eventually respiratory failure if left untreated. Most of the management for this is really going to be focused on treating the patient like you would with any other respiratory illness. We want to be aware that the patient may have also developed pneumonias because of this. So positioning is important, making sure they're sitting up, high flow, high concentrated oxygen with ventilation assistance as needed, guided by our pulse oximetry, and then IV fluid administration as well. And then if we can consider, due to bronchospasms, some type of bronchodilator, like a nebulizer of albuterol or Dulneb. Now, chickenpox, also referred to as the varicella zoster virus, is something that we also deal with. And again, like I said earlier, most EMS providers go, this is really it's an infectious disease that we have to be super cautious about. And in essence, yes, because it is highly contagious, especially if those providers are not properly vaccinated or have had a previous exposure. Respiratory symptoms are common with this in a clinical presentation. We may see some malaise, low-grade fever, and even obviously the classic rash that we would see. The rash may be the first sign of the illness and may be limited, or it could be widespread. So it could be limited to a localized area, or it could be spread throughout the entire patient. Typically, we see them on the trunk, like on the chest and areas that are warm. We also know that transmission through airborne droplets and direct contact with lesions are possible. People used to think, well, in order to get chickenpox, you actually had to touch the chickenpox. No, it's again spread by droplets. So again, being in the back of a confined space ambulance for transport without precautions is a potential risk. And then this is a disease not only for you that you have to be concerned about as a healthcare provider, but afterwards, right? So you pick up someone that may have had chickenpox, you take them to the hospital, not a big deal, but maybe you don't disinfect your ambulance well, and then you go and you pick up a cancer patient to do a transfer, or some other patient who's on some type of immunosuppressant drugs, maybe for Crohn's disease. And so you put that patient at risk from an exposure to those droplets without proper decontamination. Now, the first thing is trying to assess immunity. So you want to know, has the patient had chickenpox in the past, or have they had the varicella vaccination? Now, those are not always going to be 100% preventing a patient from getting chickenpox, or even for that matters, having more problems with shingles as an adult. It allows for us to be able to hold off that major infection initially and limit the blow to it. Your primary response is going to be post-exposure. That's going to be making sure you have standard precautions in place, and then get a vaccination as soon as you can, if you don't already have one. Meningitis. Now, meningitis is a more serious issue that we deal with as far as an infectious disease. It's very common for us to see in the pre-hospital setting, so again, it's another one that we really need to be aware of. Meningitis is an inflammation of the meninges. Remember, those meninges are the protective structures that cover the central nervous system. That's the brain and the spinal cord. And it can be caused by a variety of pathogens. Transmission factors include things like host resistance, and then even, believe it or not, weather. There's certain viruses that like to come out in certain conditions. Contact with any type of oral secretions, crowding or close contact, or even smoking can lead to infections with meningitis. Now, the clinical presentation, you're typically going to see this incubate for about 4 to 10 days. After that period of time, you're going to start to see fevers and chills that begin to develop, headaches. You're also going to see the key sign here, which is nuchal rigidity. It's where they have difficulty in putting their chin to their chest. We may also see altered mental status, malaise, vomiting, or even seizures. The big things that we're going to be looking for here is going to be what's called the Brzezinski sign. This is where flexionation of the knees causes flexation of the hips. The Brzezinski sign is where you have flexation of the neck causes flexation of the hips and knees. So in essence, as they try to tuck their chin down, they're going to draw their knees and hips up towards their head. We may also see a positive Kern sign, and we know that most of the time when we're dealing with this, it's not possible for us to get an immunization that can really do much. For meningitis, the EMS response and post-exposure, we want to obviously again observe standard precautions. You're going to see this as a really common trend in any of these types of illnesses where there's a potential for particulates or droplets to be spread. Obviously, we want to perform post-exposure prophylaxis within 24 hours, and there are medications that we can use to help treat this, primarily if it's for bacterial. Other issues that we deal with are things like influenza, the common cold, viral infections. Most of these are going to be, again, generic symptoms you would see associated with the flu or common cold. Fever, chills, malaise, muscle aches, nasal discharge, and a mild cough. They may also develop secondary infections based on an opportunistic pathogen. Management is primarily going to be supportive care. IV fluids as necessary, oxygen administration and ventilation support is necessary, guided by our pulse oximetry, and then recognizing that keeping up on standard regular vaccines, flu vaccines, are going to be helpful with influenza. The avian flu, also referred to as the bird flu, again, it looks very similar to the human influenza virus, but it typically is a little bit more serious. It leads to death more often. There's no vaccines that are available for it. And it may actually present as a worldwide pandemic. Most of the signs and symptoms you're going to see when it comes to this are really going to be focused on regular common cold style symptoms. Measles, rubella, or also referred to as hard measles. This is a systemic disease caused by the measles virus, and it's very much so communicable. It's very common in children. It's mostly common in children, you would see, but it can affect older persons as well. And most of the time, if immunity following this disease is typically lifelong, so once they've got it, or they've got the immunity, it's lifelong. And then even maternal antibodies protect neonates for about 4 to 5 hours, probably 4 to 5 months after birth. Again, it's very highly communicable with long life immunity after the disease. It's transmitted by airborne droplets and direct contact. Most of the symptoms are going to present with similar signs and symptoms to a severe cold with a fever. They may also have some photophobia, some light sensitivity, cough, congestion, rash as well. Best thing to do for this is to go ahead and get the vaccine. That's the biggest thing you could do to help prevent this. But we know that folks aren't getting vaccines like they used to because of the myth of vaccines causing autism. And so we may have rising cases of this as we continue to move forward because people are not taking the immunization process, the protections that gives us seriously. Mumps, again, another viral infection transmitted the same way, droplets and direct contact. This one is also deals with saliva. 5 to 15 years old, again, so we're talking primarily dealing with kids. What we see for symptoms is painfully large enlargement of the saliva glands. Most of these are going to be symptom-wise that you would see beyond the swelling. You're going to see cold, earache, difficulty chewing and swallowing. Management's primarily going to be supportive care, and then immunizations is obviously recommended as a primary component to hold this off as well. Rubella is another one that we've used as far as an immunization for quite some time. It's again a systemic infection. Similar symptoms you would typically see. Management is going to be the same as previous, and we'll continue to emphasize the importance of immunizations. Now, when we think of measles, mumps, and rubella, that's your MMR vaccine that you receive, and those are required for you to participate in things like school as a kid. Respiratory syncytial virus, or RSV, it's a viral infection. It's very common to cause pneumonias and bronchiolitis. It's commonly associated with lower respiratory infections during the winter. My daughter actually suffered from this and had a pretty severe case of RSV, was hospitalized for 2 weeks, and because of that. So, but initially, symptoms were runny nose, congestion, followed by a little bit of wheezing, tachypnea, and then signs eventually of respiratory distress, and can progress to respiratory failure. Management with any kid is aggressive airway management, oxygenation, in order to ensure that we know that children without respiratory arrest, respiratory failure, leads to cardiac arrest, and so we want to try to hold that off. Pertussis, or whooping cough, another one that we get treated for. It's a bacterial infection. This, and again, is going to be something you can get immunized for. Most of the symptoms are going to be noted by the persistent cough. And then obviously management is going to be isolation precautions for you, and then hopefully immunization and treatments later on for the child. Mononucleosis, this is mono, kissing disease, right? It's a viral infection. It's based on the Epstein-Barr virus, transmitted through oropharyngeal contact. That's why we call it the kissing disease. Symptoms: fatigue, followed by fever, severe sore throat, oral discharge, and enlarged tender lymph nodes. It's oftentimes hard to tell if someone has mono or if they're just sick. Herpes simplex virus type 1. This is a viral infection. Again, this is what we're talking about on your sores, on your lips, your cold sores. Most of these symptoms, you're going to get these fluid-filled vesicles, or little pus pockets that will burst open and develop into sores or even blisters. And then they actually begin to kind of have become little ulcers because of that. Most of the time you're going to see with this is some fever, maybe some malaise, dehydration may also occur. Management's typically supportive. Epiglottitis, we're going to spend a lot more time talking about this in our PEDS class, but it's a true emergency for kids. We see this where they're having significant difficulty breathing, they're having difficulty moving air, they have excessive amounts of drooling, they're in a lot of stress, you're going to hear audible sounds of stridor, they may have a fever or sore throat, difficulty swallowing is another big part of this. Epiglottis is enlarged and infected, so if it becomes stimulated or irritated, it's going to swell and it's going to occlude the airway, as we know that the airway in children are much smaller than that of adults in relation to the size of their epiglottis. Croup is a little bit different. Croup is a viral illness causing upper airway obstruction. It's actually just below the larynx, and characteristics is that seal bark, that bark that these kids will get as part of their cough. Typically it's seen at night where it gets worse, and things like humidified oxygen can be really helpful as part of that, but it is another serious illness. Pharyngitis, this is where we're talking about the infection of the pharynx and tonsils. Sudden onset of sore throat. We get a lot of swelling and issues that go along with that. Very common in 5 to 11-year-old patients, and can lead to scarlet fever. Sinusitis, this is the paranasal sinuses are infected. You may get a lot of drainage, a lot of pressure, maybe even some blood that may come out of that as well. The hantavirus, that's another infectious. This one's carried by rodents, characterized by fatigue, fever, aches, nausea, vomiting, diarrhea, and abdominal pain. And it can lead to severe myocardial depression as well. The hantavirus can. Gastroenteritis, this is a big one. This is where we're going to be, something has caused us to have upset GI, nausea, vomiting, cramping, or discomfort, and then diarrhea. Typically, it's a virus, bacteria, or parasite that we've ingested, and it includes things based on when you ate it, what you ate, if it was properly cooked, if it was properly heated to the right temperature. Those types of components all become a concern when we think about gastroenteritis. The biggest thing that we worry about is this is a short-term limited time period, but there are those that are at higher risk. So the older you are, the more of a risk you see. Those that are going to be doing international travel, and then contaminated food or water supplies. Management's typically supportive to help offset some of the nausea, vomiting, and dehydration. Food poisoning, characteristics of this are going to be typical. Most of us have probably had food poisoning at one point or another, or will throughout our life. Very common for bacteria. E. coli is the primary one we think of. Undercooked meat, and then it's a very potent neurotoxin that's released because of it. So we see diarrhea, vomiting, and a significant amount of gastrointestinal distress. It is enough for someone to have to actually call an ambulance for. Management's going to be relatively simple. It's again focusing on antiemetics, fluid replacement. Encephalitis is an infection of the brain. Typically, it's viral in nature, commonly coexists with meningitis. And we see with the clinical presentation, decreased level of consciousness, fever, headaches, drowsiness, coma, tremors, and even a stiff neck or back. Management includes taking standard precautions and then treating the patient primarily for the signs and symptoms that they present with. Rabies is another one that we see that infects the nervous system. It's a viral infection transmitted through bites, non-intact skin, and other direct contact with any type of mucosal membrane. The big thing that we're going to see here are going to be malaise, headache, fever, chills, sore throat, common cold, things that we would typically see up until we hit the encephalitis phase, which is going to be a lot more excessive motor activity, excitation, and then even agitation as that begins to affect the nervous system. Most of the things you're going to do as far as management goes is going to be inspect and irrigate the wound. If someone's been bit by a dog, the most important thing is scene safety, or some other animal, right? Is scene safety, your safety. And then once you make patient contact, the infection is the biggest concern that we have with that type of injury. For tetanus, bacterial infections, so again, of the central nervous system, symptoms are going to include nuchal rigidity, or muscles that are going to be close to the infection site. We may also see issues with generalized locking of the jaw. Management for us is going to be pretty basic, but again, it's really focused on the immunization. Lyme disease is one typically caused by ticks. We see initially what's referred to as a bullseye rash. We want to see where that begins to spread. If it spreads, it can actually go ahead and spread to the nervous system, the heart, or even joints, and eventually up into the brain and cause a lot of different components depending if it's an early dissemination or if it's late. All right, so for this next session, I want to make sure that you guys are aware. Be cautious because we're going to be talking about sexually transmitted diseases. Infectious diseases transmitted through sexual contact are known as sexually transmitted diseases, or STDs. They represent some of the most prevalent communicable diseases that we see. A variety of bacteria, including gonorrhea, syphilis, chlamydia, viral issues like HIV and herpes, and parasitic infections are all spread by this route. Other illnesses that are generally not considered to be STDs include Hep A, B, C, or D, salmonella, or even shingles. May also be transmitted through sexual contact, but it's not considered to be an STD. We're knowing that STDs are going to be primarily affecting the sexual organs or the genital organs, and are going to result in a pathology of the reproductive structures. Although EMS responders do not treat these diseases, other healthcare providers commonly have this information, need to know this information based on the different cases that you'll see. Your knowledge of these diseases will put you at on a level playing field with those folks, so you can be able to bolster your credibility and then interact with them in a meaningful way. Most of the things we're going to do for these patients is going to be to transport them, recognize the fact that they may have some type of STD, take and observe standard precautions, and then avoid contact with any lesions, and then make sure that if you do come in contact with anything, or regardless, wash your hands vigorously after exposure. That's probably the biggest thing that we can see. So caution as we get into some of these photos. Gonorrhea, it's a gram-negative bacterial infection transmitted by sexual contact. Most of the symptoms that you're going to see with gonorrhea are going to include localized things like discharge, painful urination in men. You may also see issues with prostate or other urethral structures. The majority of women that contract this disease have actually no pain or even minimal discharge. In some cases, symptoms include urinary frequency, vaginal discharge, fever, and abdominal pain. Pelvic inflammatory disease often results after menstruation when the bacteria spreads to the cervix and then up the genital tract. Affected women are at an increased risk for sterility and ectopic pregnancies, along with abscesses within the reproductive structures. For syphilis is a disease that is transmitted by direct contact with folks that have a syphilis lesion, again, most likely through close sexual contact or physical contact with that lesion. It's characterized by these lesions that involve virtually any organ or tissue that it comes in contact with. And frequently, if someone has this, they're more likely to end up having it be a relapse behind for this. There's a number of different stages that you end up having with syphilis, and it's typically going to be progressive as we deal with that. Genital warts, this is another one that we typically see. Genital warts are very highly contagious. Again, it's going to have a caulicle-like fleshy growths at the end of the penis. It could be the anus, labia, surfaces, and any type of mucosal membranes in the genital region. Again, very highly contagious, affected by sexual transmission. Herpes simplex 2, this is different than simplex 1. It again is transmitted by sexual contact, and these are vesicular lesions on the penis, anus, rectum, mouth, vulva, buttocks, legs, or perineum, anything that would come in contact with one of these lesions. These can heal, but they can occur again throughout the patient's lifetime. Chlamydia, this is a parasitic infection transmitted by sexual activity and hand-to-hand contact of eye secretions, believe it or not. Characteristics can be similar to gonorrhea, but it can cause blindness and sterility. Trichomonas is a protozoa parasite infection transmitted by sexual contact. Males are typically asymptomatic as carriers, but we see a lot of vaginal discharge, irritations of perineum and thighs, along with some discharge. Again, oftentimes will go along with or be partnered with gonorrhea. Another one we look at here are going to be highly contagious bacterial ulcers. Inflamed ulcers you're going to see that can appear anywhere in the genital region. Again, very highly contagious. Impetigo is another bacterial infection that we see. Again, highly contagious, spread by direct contact, and it's typically is what's caused by some type of staph infection. These lesions most commonly occur in the extremities and in the joints, and we need to take standard precautions, just like you would if it was any type of staph infection. Lice is another parasitic infection. Commonly occurs in the scalp, trunk, and then in the pubic areas. One of the biggest things that we know is that lice alone is not an emergency, but repetitive infestations can actually lead to an allergic response. And so that's something that we do need to be aware of, that someone that has had lice that's having an unaffected, unknown reason for an allergic reaction. Scabies, this is an example of mite infestation characterized by intense itching. We're seeing lots of sores all over the body, little bite marks. These are things that can be affected by contaminated clothing or anyone that they've come in contact with that had scabies. There are also scabicides, which are going to help you control. Nosocomial infections, these are hospital infections. These are typically going to be antibiotic-resistant infections because they're hanging out outside the hospital. They're ready to go. These are viruses that are primarily going to be, again, antibiotic resistant, and they're going to be found in the hospital, and something that you don't want to get if you can help it. We also talk about patient education. With patient education, obviously the role of the paramedic is to recognize what's going on and then to educate the public, as we've talked about. We want to try to make sure that we're being proactive when it comes to infectious disease, and that when we introduce disease transmission as part of our community interaction, whether it be CPR or first aid or any of those components, we want to try to remind folks that hand washing is extremely important, minimizing touching your faces or other regular use surfaces around someone who's contaminated is a big risk for picking up that disease. So the question then becomes, well, how do you prevent that disease from transmitting? Well, personal accountability is probably the most important factor here. You're only as safe as you are going to, as the precautions you're going to employ. So first, ensure your own personal health. Do not work if you have diarrhea, if you have a draining wound, you have some type of mono, you've got a cold, untreated lice, scabies, strep throat, or even our jaundice, right? Make sure you are healthy if you're going to work. We don't want to spread disease to others. We also want to maintain our current immunizations. That's our MMR, our Hep B, our Tdap, our polio, our chickenpox, our influenza, and rabies as well, if appropriate. We need to make sure that we're using our full BSI and PPE to help control the spread of that illness. And then keep your education current. There are basic factors for infectious disease, but we know in today's world there's a lot of viruses and a lot of illnesses that are out there, and they can change pretty rapidly. So being up to date with what's going on with infectious disease is very important. We know that we also talk about sepsis when we deal with infectious disease. Sepsis, also sometimes referred to as systemic inflammatory response syndrome, or SIRS, is something that we may deal with. Sepsis or septicemia is the most common cause of death in debilitated patients in the hospital or intensive care units. Life-threatening medical conditions caused by a whole body inflammatory state causes a systemic inflammatory response. And that inflammatory response is really, really bad for everything from blood vessels to our patients to really you name it. We also know that with SIRS, original site of infection can be anywhere in the body. The infection can then spread to a vessel, and from the vessel it becomes systemic. Sepsis can result from a medical intervention and devices as well. So it's not just that they get an infection, from breathing in some type of localized infection from the lungs or maybe from a sore, and then it leads to an infection of the blood. It can actually happen from surgeries. It can happen from medical devices that are being placed in, catheters, things of that nature. We know that there is at risk of patients who are more at risk for developing sepsis. This is patients with immunosuppression. There may be on immunosuppressive drugs, or they're in an immunosuppressive state. Patients who are hospitalized are a higher risk for this. We know that if they have pre-existing infections or other pre-existing medical conditions, are at a higher risk. Severe trauma patients, especially if they're breaking open any skin. And then the very old, along with the very young. And there's also, believe it or not, those that are actually more genetically likely. They have a higher tendency for sepsis than others. Most of your signs and symptoms for assessment are going to be looking at things like heart rate, abnormal body temperatures, tachypnea, obviously white blood cell count, or doing a complete blood cell count. And in severe sepsis, the presence of sepsis and evidence of hypoperfusion, we're going to see septic shock. With septic shock, we're talking blood pressure now that's below 60 millimeters of mercury. Maintenance of a mean arterial pressure above 60 is going to require vasopressor activity therapy. So if we're going to try to keep them above 60, we're going to need to be aggressive with some of that fluid resuscitation and even consider some pressor agents. Early recognition and aggressive treatment is necessary for best outcomes. I'm going to leave a link into the lesson here that will take a look at the state protocol for sepsis. The early goal is for direct therapy. And so supplemental oxygen with or without intubation based on pulse oximetry. They may need central venous lines placements. At least they're going to need fluid resuscitation and then maintaining a blood pressure as best we can if we're dealing with these folks. We also know that we're going to have the use of broad spectrum antibiotics to help treat this as well. So in summary, we've talked about a lot of different components. We talked about public health principles and agencies. We've spent a lot of time on microorganisms, the contraction, transmission, and the stages of disease. We've talked about the body's defense against disease. How do we take infectious control in the pre-hospital setting, and how do we manage and assess these patients with specific infectious diseases, and then how do we prevent those from happening by educating our patients in the community, and then really focusing on the best treatment for infectious disease is preventing the transmission, and so we spent some time on that as well too. So I hope this lesson was useful for you, and as we go through, we'll catch you on the next one.